happy to be here. I want you to see a big smile on your face. I'm seeing so many smiles in the room. In fact, some people are laughing, so we're getting more than a smile. We're really excited to be here. Today is the day that we've been really excited about. We're seeing a lot of familiar faces in the hall, and a lot of great work has been going on. So we're really excited to celebrate the sharing of the global health program in collaboration with the Ministry of Health. So my name is Estelle Mande. I'm the founding partner of Ducit Solutions and also the in-country consultant for the Global Health Workforce Program. And I'm going to be one of the moderators today. I'll hand over to my very good colleague, Mr. John.
Thank you very much, Thomas and Steve, by the way. The founder of the Ducit Solutions. I always make care of us. The client I see that and the solutions are around the corner. Thank you very much. So today we are come to this program, the learning and sharing of this partnership program that has been on for a period of time. So today is actually very relevant for us to explain what we've done, how we can share our knowledge, and how we can solve it. Like as I said, my name is John Tolia. I'm from the Federal Ministry of Health and Social Welfare and the Human Resources Development Branch. So, by the special grace of God, we are going to take you through the activities of today. We're sorry that we're starting a little bit late, but we are very sure that we're going to meet up with time. We can't keep us here waiting by one extra minute. Thank you and all welcome.
Great, thank you so much. Like I said, like Mr. John said, this is a huge opportunity to celebrate the outcomes of this program and highlighting some really great work that the health partnerships have been doing. So we'll just start with some housekeeping, which will be taken by my colleague, Adenike Badura.
A dynamic individual before, one of my boss, and he said, when you are meeting agreements, they don't answer you the first time, but by the time you repeat what you said, the second time they always call us, the greeting. So I say you're welcome once again. You are welcome once again. The feeling is always right. Very comfortable nights. For those who are staying here, if you have any issues, please let us know so that we can get it resolved.
Okay, I'll
so
check it.
we all know that the global network that we have here to celebrate today. Here is Nigeria, on the program covers 3 countries: Nigeria, Ghana, and Kenya. So if you look at the board, you see that the focus is developing the network force to build strong, more resilient, persistent, and advanced progress towards UBC. So we have gone through that, and we just want to be able to assess how far have we come to advance progress towards UBC as it is written here. So today we will, by the end of the program, be able to assess that with assets. On that note, I want to recognize the presence of some people. Everybody here has ordered, but we also want to give honor of this team. We will recognize the presence of some people, and others have been called to recognize as well. So here I have Dr. M.D. Olatuki, who is the Executive Secretary for the State Private Healthcare Board. Dr. Olatuki, you are welcome. Thank you very much. Also in our list here is Dr. Shehu Usman Abdullahi, who is Director of Medical Services from Paris State. You are welcome. We also have amidst us here Dr. Mary Bravo, who is WHO Health Systems Strengthening. So she is the cluster head of the Health System Strengthening in WHO. Madam, you are welcome. We learned that the doctor rep will be coming. So, all right. So as he comes, we also recognize him. You are welcome, madam. So on that note, we want to proceed to the goodwill messages. We have on our list here some selected organizations and individuals that we expect to have to give a goodwill message. I will call them in order here. Then anyone present here would please come up. I want to call the representative of the SDO. It is here. SDO. Okay, it's not yet here. Right, I know that WHO is here. So WHO is here. The MDCN. MDCN here. Okay, fine. Then we have the National Postgraduate Medical College. Postgraduate Medical College is here. Oh, fine. Thank you, sir. Then we have the National Private Healthcare Development Agency. Yeah. FDA. All right, we are still expecting them. Then the Nursing and Midwifery Council of Nigeria. Good. Thank you. Then we have the Pharmacy Council of Nigeria, PCN. Okay, not yet. Okay, we are still expecting him to come. Then the founder of Wellbeing Foundation. Okay. Oh, Wellbeing Foundation. Fine, that's fine. You are there. Thank you very much. On that note, I think we want to invite the representative of WHO to give us the goodwill message. We can see you from there. I think all of you want to see her. So that's why we really have the top level.
Please be careful not to touch anything.
I learned from the that I need to say a second time. So good morning. I'm happy to be here on behalf of the World Organization. So I would like to acknowledge being essential Honorable Minister of Health and see the directors that are here. Also for the British High Commission, the directors, the academia, thank you very much. Members of the different boards, the trustees. I know the trustees, sorry about that, the trustees. On behalf of the World Health Organization country representative, Dr. Walter Hazard, I bring you greetings. And I will make these remarks on his behalf. WHO is indeed very pleased to be here. It is hard work at this event to share and to learn and to gain insights into the experience of the success of the health partnership component of the global health program. This investment is indeed very much needed as we focus on issues concerning the health workforce in countries including Nigeria. The strength of every health system reflects the capacity and adequacy of the health workforce who are necessary to deliver quality services to address the population health needs. Therefore, WHO has called for more investments in human resources for health, for countries to be able to meet the sustainable development goals and to achieve universal health coverage. Also, for a resilient and effective health system, we realize that Nigeria must have adequate numbers of health workers who are fit for purpose, motivated to perform, and equitably distributed to enhance equity in access to their services. Currently, according to the World Health Organization Health Workforce Support and Safeguards is 2023, Nigeria ranks among 27 countries with critical health workforce shortages. Nigeria is estimated to have 1.83 health workers per 1,000 people, far below the WHO threshold for 4.5 healthcare workers per 1,000 people for adequate healthcare coverage. We therefore commend this program on the progress it has made in just a little over a year to contribute to Nigeria's vision to address the health workforce. We also recognize that this is in line with the steps taken by the government of Nigeria to mitigate the challenges of human resources for health, including expanding the capacity of institutions and developing and implementing policies for managing the health workforce situation in Nigeria, including the migration of health workers. From WHO, we are committed to support this process in partnership with this project. And we have two projects that we are working with together with the United Kingdom government to increase the capacity and the production of frontline workers in schools, as well as increase and develop evidence-based policy strategies and tools to change the health of workers. Distinguished ladies and gentlemen, beyond this global health program support, we also recognize the need to build strong partnerships, and I guess that's why we are all realize there are so many stakeholders here, and it's important to have this partnership to be able to direct it to strengthen the health workforce. So we look forward to see the results that have been achieved so far on this project, and we also pledge that WHO will continue to support the government of Nigeria and this program, working together to strengthen health workforce and also work with other partners, including the global health partnerships. I thank you all for your attention.
Thank you very much for the good, and I'm very sure that we can all have everything she said. And if anything I can take home is that we we give her a round of applause, please. Thank you. Thank you. So, before I call in to give us the good message, I want to recognize the presence of the Nigerian People Association. The representative of the Nigerian People Association. You are welcome, sir. Dr. Iris. Thank you very much, sir. So, we proceed with the good message. I don't know if MCM is here now. Okay, MCM is not here. And we have the Postgraduate College. All right, not yet here. That's all. Fantastic, sir.
Good morning, everybody. Let me start this protocol on behalf of the President of the National Postgraduate Nigeria. I want to say thank you to the organization. We partnered with you through the Council of Faculty and the great well wishes of the college and the women of Nigeria that was led in organizations across the 60 local zones of Nigeria. And this will go on.
We want to go ahead. Do we have the National Party Agency? Not yet. So, I know that lots of different council is there. So this time will come and give us a good message. A round of applause as it comes. Thank you. Is it that put this step down? Thank you, thank you.
Good morning, all. The state minister of President and every participant here. I want to welcome us all to this great occasion global health. On behalf of National Free Council, we want to welcome everyone, and National Free Council remains committed to fostering excellence in the nursing and medical education through continuous education, policy making, policy strategy and action. So, as we engage in this meaningful discussion, we want to encourage everyone of us to fully we want to encourage everyone of us to put make sure that celebration, and on behalf of those National Council, I want to wish us a productive and impactful event. Thank you very much.
Thank you very much, National Council representative. Thank you. We appreciate you. And we know how important you are as a body in strengthening the health system because of the life population. So you are an integral part of this program. Thank you very much. So we have the PCN here. PCN. No, PCN is not here. So I'm taking a pause. You might be wondering why I have to pause. I'll let you know. Thank you. So, do we have any of the representatives here that we have mentioned to give the good message? Any of the MCMs here? MCM. Oh. Thank you very much. Yes, do briefly, and let her know that it's just time before her to give us a good message. So, but if there's another person here to give us a good message, we don't mind that person can all the other have to settle down. We will try to settle so we can proceed. And I want to call back Mrs. Anelika to also take us through one of the items on the second activity, or on the third activity also. That's objectives of the event.
So very briefly, as you all know, we are here for sharing and learning, and it's all about information sharing. We want to discuss the achievements and facilitators of the success, as well as the progress on the key themes of the Global Healthcare Workforce Program. It's also all about networking and so as partners on the GHWP. So get to know who is L95, get to know who is SD41, get to know who is L0, just to make sure you network and know the contacts before you move this road today. Also, it's all about problem solving. We want to reflect on the common challenges we encountered in the course of the year implementing the GHWP in country, and what opportunities did we identify that we build on. We are talking about scalability and sustainability. So from here, we are moving forward. Then we also want to identify the national level touch points and the sustained the government, both at national and subnational level, as the various geographies where we implemented the GHWP program in Nigeria. So please, it's going to be an engaging session or two. Let's be ready to participate effectively. Thank you very much.
Very much for giving us this direction as well. So we are going to proceed. Now, if you look at our activity on the agenda with you, the next would have been the opening remarks to be given by the Director of Health Research and Statistics, Federal Ministry of Health and Social Welfare. But we are still expecting him. We are going to skip that. So anytime he comes, he will give the opening remarks. And the same thing, we're going to skip the. Okay, let me just find out. Is the Director of Public Health here? Federal Ministry of Health? Director of Public Health? Okay, so we're going to skip that because I think he will be one that will give the keynote address or join the two together with the director. So on that note, we need to move now to the icebreaker activity. Okay, fine. My attention has just been drawn that we are giving some little time for the registrar of MDCN to settle down. So on that note, may I humbly invite the registrar of MDCN to give us a goodwill message.
Because of this 1 year, you just write it on that business. And then if you are just like and indirectly involved, and you have the expectation, you are like they are coming for sharing and learning. What do we want to do? So just write that expectation there. So I'll just give us like a minute to do that. Okay, so the health partnerships, you've had some very proud moments during the course of your project implementation. So I would like you to just write it on it. So on the end of the note, just write proud moments. And then write it, you are proud that I was able to train 10 doctors, or we had the Jersey components, we were able to go to a rural community, anything, just put it there. Then for those of us that were not directly involved in project implementation, you are here and you are just seeing so many things we are doing. So you are not sure, but you have an expectation. On your own stick note, you write expectation and just put what you expect to gain from the learning event. Is that enough? Okay.
That is very clear. She will also be repeating as we are writing. How many minutes are you giving?
I will just give us 4 minutes to write it.
Okay.
And then if we are done, I would like us to just stand up a bit. Sorry. It's just an exercise because, you know, one of our objectives is to network, to meet with people you have not met before. So you are going to show it to somebody you don't before, somebody you have not really been directly so involved with. So you just show them your age. And if you look at the side of this, see that we have on the flip charts, on the wall, we have expectations, and then we have proud moments. On that other side, we also have the same. So we'll just stand up after you have finished writing, and then you share with somebody, then we stick it on that note.
Right. So we'll take our time to do that. The time allocated here is 20 minutes, and very sure we'll spend over 5 minutes now. So our timekeeper is monitoring. Dr. Joe is dancing because I'm sure that you have written a very good one. Dr. Joe, I can see you from here.
Okay, I believe we're all written. Can we please stand up?
we have all written, can we please?
So this is also an opportunity to take a head break. We'll start for some time.
Just
We
exercise
just stand
our
up and
heads.
stretch, and then you now go ahead. If you are in front, just go to the back on your side. Somebody not really familiar with, and share your proud moments and expressions. Yes, my since yesterday we went together.
Yeah, that's great.
Okay, please, let's. Okay. Now we are going to take the post-it notes on flip charts.
Please, can we try to stick the notes on the flip chart? Side, right. Please, can we do that?
Say right kit here. Have 1 minute. Please, just with your just put it on the flats. Okay, please, can we now go back to our seat? Thank you very much. Can we all go back to our seat, please?
Please, can we try to round up our networking discussions? So stick our notes on the flip chart so that we can sit down on our various seats and continue with the program. We also want to inform participants that we have accredited photographers who are wearing tags. So those ones are the ones that the organizers have accredited to take you photographs. But if you wish and feel like taking photographs from the other people, then you will not have your own contract with them. So please take note. The ice protection was going on, we noticed the arrival of our dignitaries that were expecting to give us the goodwill message, which is known for and they call their attention, give us the message. And from what here, we have the representative of SCDO in the person of Dr. So please, we will expect you to come and give us a good message on behalf of Thank you very much. It's just solid 12 minutes. You don't have a prepared date, but just solid 12 minutes. Thank you very much.
Yeah, good morning, ladies and gentlemen. With your permission, I will stand on existing protocol. It's my great pleasure here. It's my great pleasure to be here today. I still remember, I think it was a little more than a year ago or so, when we were launching this program, and that day it was wonderful. There were so many hopes, so many thoughts in our minds about what we were going to achieve from this program. And it's really, really great to be here today to see, some of the great achievements. I've been following this program throughout this last 1 year, and it's amazing to see what some of these partnerships have achieved, working all around Nigeria, strengthening health workers and health systems in Nigeria. It's amazing. I just say big congratulations to all the grand partnership work you've done. It's been amazing, and I'm hoping that the lessons we learn here today we can take some of these lessons that we've learned over the last year and take some of these forward and scale them up across the country, and some of these things will expand even beyond, the small grants that we've had, and also in years to come, hopefully, we will see, some of these programs and some of these interventions on a much bigger scale. So thank you very much, and on behalf of UK, I'd like to say welcome and congratulations to everyone. Thank you.
Thank you very much, Dr. Ebere, for the good message. Thank you very much. A round of applause for him, please. Thank you. He look forward to seeing the outcome and the impact of this program in the near future. And that's what all of us are looking at. Because if you do a program and you don't have benefits of it, it's as good as not doing it at all. So we are all looking forward to reap the benefit of it in the near future. Thank you very much, Dr. Ebere. Okay, so I recognize the presence of Dr. Jinaidu Inua, the Director of Planning, Research and Statistics in Niger State. Dr. Inua, you are welcome. Thank you very much, sir. Thank you. Thank you. So, like as I said before, we had two people that came in there that we were expecting to give us the goodwill message, and Dr. Ebere has given his own now. So I want to respectfully invite the founder of the Wellbeing Foundation, in person of Her Excellency Dr. Toyi Saraki, to give us our goodwill message.
Good morning, everybody, and I hope all due protocols were obviously established so that I may stand on all the protocols. Esteemed ministers, distinguished guests, healthcare leaders, partners, and advocates, good morning. As the founder and president of the Wellbeing Foundation Africa, it's an honor to stand before you today, I think a year after these partnerships started, at this pivotal sharing and learning event of the Global Health Workforce Program. I extend my gratitude to the Federal Ministry of Health and Social Welfare, the Global Health Partnerships, Ducit Blue Solutions, and our own leader in our health partnership, the Liverpool School of Tropical Medicine, for your leadership, your tenacity, and your dedication in strengthening the health workforce in Nigeria. The Global Health Workforce Program is a transformative initiative designed to optimize, build, and strengthen the health workforce, supporting more resilient health systems post-pandemic, and advancing progress towards universal health coverage in alignment with the United Nations Sustainable Development Goal 3. Through its health partnership initiative, the Global Health Workforce Partnership fosters cross-border learning and capacity strengthening, ensuring that health professionals are well equipped to provide high-quality care where it is needed most. A critical pillar of this initiative is the strengthening of emergency obstetric and newborn care, because Nigeria has one of the highest maternal and neonatal mortality rates in the world, with a maternal mortality ratio of over 800 deaths per 100,000 live births and a neonatal mortality rate of 33 per 1,000 live births. These numbers actually highlight the urgency of the mission of these partnerships to equip our healthcare workforce with the skills and resources necessary to save lives. Our ongoing partnership with the Liverpool School of Tropical Medicine, the Wellbeing Africa, in advancing training for resident doctors in Nigeria, led by the Liverpool School of Medicine, is already demonstrating tangible impact. The GHWP, we have launched Advanced Obstetric Surgical Skills Competency-Based Training Program, integrated that into the National Postgraduate Medical College of Nigeria's residency curriculum. This initiative is not just about training, it's about ensuring sustainability through centers of excellence in Lagos and Abuja, where faculty members have been empowered to cascade knowledge and skills to obstetricians and gynecologists for many future generations to come. The AOSS training stood as a 3-day intensive program, followed by 2-day training of trainers, provides residents with hands-on experience in life-saving procedures such as emergency cesarean sections, post-management, and neonatal resuscitation. These skills are further reinforced through simulation-based learning and objective structured clinical examinations, ensuring confidence in managing obstetric emergencies. To all the frontline health care workers today, especially to the leads of nursing and midwifery, who are very dear to my heart, you are heart of this effort. Your dedication to improving maternal newborn care will have a lasting impact on families and communities across Nigeria. To our government and development partners, let us commit to ensuring that every trained doctor, midwife, has the resources and institutional support that they need to sustain and scale up this progress. Looking ahead, the success of these programs depends on sustained investment, national policy integration, and continued collaboration. And much like Dr. Ibere, I've been keeping my eye not just on our own partnership, but on all the other partnerships. I was particularly excited by the project that's helping pathologists in Nigeria conduct better forensic pathology, and we believe that the skills that are being imparted translate into systemic improvements that will endure long beyond this initiative. The Global Health Workforce Partnership has laid the foundation, but it is up to all of us to build upon it. Once again, I'd like to extend my sincere appreciation to all our partners and stakeholders. Their unwavering commitment to strengthening Nigeria's health workforce. I also thank the Foreign, Commonwealth and Development Office of the United Kingdom for actually structuring this investment program in aid and development programming at the front line that will be so helpful to us, especially at this time in the world other nations are reducing their aid budgets to Africa. May this serve as a catalyst for deeper collaboration, knowledge exchange, and lasting change in our healthcare system. Thank you very much for this opportunity to speak. Thank you.
Thank you very much, Her Excellency. Thank you very much. Thank you very much. Please, a round of applause for her again. Thank you. Thank you. She took her time to prepare her own goodwill message. Yes. I know that for us will be to get detail. Yeah. If you want people that you know and I know that here also among people give us a good message. Are you ready, sir? Yeah, so you can come briefly. Thank you. A round of applause for him. Thank you very much, sir.
Thank you. Okay. Okay. Good morning, all. I want to appreciate Global Health Force team, the partners that are here. But very importantly, I want to appreciate the Honorable Minister of Health for providing the quality stewardship for the health sector. The Director Health Planning Research and Statistics, whom I believe is ably represented here. As a regulator, this is one aspect of regulation that is key to ensure that regulation out effectively delivered, because is most very much important factor within the healthcare system. You have all the infrastructure, you could have all the needed technologies. If you don't, it takes to drive Now, of a regulator, certain pillars are very important. Training, the training institutions, the capacity to structure, as well as human resource. Because to find the to that, capacity important. Today, what producing us at the system, what the Honorable Minister is pursuing to ensure that we improve the turnout, the output of our putting strategies in place to double this production. But how do we match that with the requirements to recently the Minister of Education, the Honorable Minister of Education, having moved from health and having a good understanding of this background, is trying to put in place a mechanism where these facility institutions will be adequately supported from the THET fund. When we will achieve that, another key aspect was land ourselves need to have appropriate number of training centers where the interns or their house officers can be trained. Again, the Federal Ministry of Health is convening a meeting sometimes on 27th of this month to discuss how we can achieve easy uptakes of these interns when they are produced, because even when they are produced, the training, the internship also becomes a challenge. Another critical factor is the issue of skilled distribution of our health facilities. And that again, from PCN, we are looking at the perspective of coming up with strategies to ensure that these resources, when they use, are able to extend innovative ways. In fact, in PCN, we are looking at coming up with something like satellite pharmacy, so that we could promote, we could push access to the audience. Another key pillar in human resource, of course, even after training, the issue of continuing education. This we are achieving greatly. We are repositioning. And of course, not only driving it based on what we were used to doing. I'm sure the recent challenge, the epidemic has actually opened our eyes on the fact that we need to learn new methods and new technologies. Very importantly, too, in PCN, we recognize the fact that we have left behind the issue of compounding of medicines. And we are bringing on board to be a professional pharmacist and your ability to produce things, which of course will reduce the burden in terms of cost of education. This we are doing with the and here I can't. Thank you very much.
Very much. Round of applause for. Thank you very much. Just like the FDCN registrar, and you can see two of them now tapping. You see the same line as after I'm taking this way that speaking of the same line. So thank you very much, regulator. He has mentioned a lot of things who we see prove because regulator to make why and how to get those things done or supply cars out very much Thank you.
sir. His registrar of my and acknowledge him. Men of honor. Thank you, sir. So thank you so much. As men of honor, we join hands. That's the pharmacist. Yes, sir. I just to recognize the national mechanism that started this program for us to deliver this program. Got members from that mechanism in the house, starting with our chair of the National Oversight Mechanism, the NOM. I want to recognize Dr. Mwakego Chukwuko. Thank you so much, Ma, for the work.
Thank you.
Thank you. Sorry. The non-director of PPP and the diaspora desk at the Federal Ministry of Health, former assistant director, deputy director, health systems strengthening. So much great work. Also got to Abani Atuku from the FCDO. Thank you for all the support. We've got some other non-members. I'll start with my colleague standing here, my co-moderator, Mr. John Okobia, who I always say that I'm learning from. I learn from him every single day. Thank you so much for your work as the National Oversight Mechanism. And we also want to recognize a couple more that are not present here. We also want to recognize, the media were covering Dr. Ojo. I'm so sorry, he was covering you. Thank you so much, sir, from the WHO for the great work for supporting the program. We've also got a colleague from MDCN, Dr. Victor Benro, and Mrs. Chigozie Kasim. I think that's the 7. So in the program, we have 7 national oversight mechanism support. And we really could not have implemented this without this. So thank you so much.
Thank you for recognizing and appreciating the work of the NOM, the success of this program. Thank you much. So on the air now, we'll be showcasing the health partnerships and the program. It's going to a video story showcasing of UK, Nigeria, and he has to take us through an overview the Global Health Workforce Program across programs so far and specific to so right here, so shows that of Nigeria, if time permits again. Okay, the video covers all of them. They will show us what the other countries are doing so that we'll be able to learn and share our knowledge across. So the person to take that will be so that will be taken by Mrs.
Okay. Hello, everyone.
Thank you.
That theory is always right. Hello, everyone. Thank you very much. So we want to take you through the partnerships program. We want to showcase what we've been able to achieve in the past 1 year. Before I go on, in our folders, we have the brochure for this event, and that actually speaks to all the grants that have been implemented under the Global Healthcare Workforce Program. So far, you can also look at the screen beside you and the one here. In this 1 year, the GHWP has been able to train 2,577 healthcare workers. I was expecting to hear a round of applause. We've also been able to, among the healthcare workers trained, we have 62% of them as female and 867 male. So, the areas where these healthcare workers have been trained include gender equity, and inclusion, mostly in clinical areas, and some is also in leadership for girls. Out of all the 2,577 healthcare workers trained, 92% of them reported improved knowledge or skills in their. I think that is massive. It simply means that also we'll be able to enhance three training curricula. First is the basic emergency obstetric and neonatal care for maternal and newborn care training curricula. We also enhanced the glaucoma competency for nurses, as well as the breast cancer care and management multidisciplinary team training. Next slide. So we made effort for strong healthcare workforce in Nigeria. We've had some lasting impact. The leadership, mentorship, and the innovation. So we've been able to contribute to establish structure by fostering long leadership and professional growth. And we have examples for elementary. That's the early development bi-directional. We have UK professionals mentoring at the below to early childhood management program with trainers providing solutions for breast cancer patients. Also, SG48, mental health and psychosocial support, as well as a neonatal care program, where a WhatsApp platform where all the trainers and they share innovations, they share new trends in care and management. They also share materials and they're able to interact and seek guidance to manage cases that they come across daily. Second, we also had we had integrated new curricula, policies, and training for international health educators. We have examples of L95. Co-develop the work for human resource health management. The example right that's which developing curriculum for service or for primary health care as LGA3. L3 has been able to develop for using digital technologies for clinical training in school and midwifery. Then we also able to develop the Nigeria occupational health training. Please go up for that. And the health partner that worked on that SG to clinical training to over 1,100 workers, whereby enhancing action, career growth, 110 on their emergency obstetric and neonatal care training. Likewise, we'll be able to strengthen HRH data system, and we've supported workforce strategies to optimize health worker distribution. Policy 95 has been able to work on this effectively with MA to information system for HRH in Nigeria. So please, let's give ourselves a round of applause for these milestones once again. Thank you very much. So now we have a very short video as a narrative or a compendium of our achievements in the last 1 year. Media.
The health workforce is at the center of every health system. However, many countries are grappling with major workforce challenges, such as critical shortages in the supply of workers and in a skilled workforce, distribution of health workers, and their competent motivation performance. The Global Health Work Program was in help and Ghana and Nigeria to contribute to better health management, higher education, training, and to build stronger, more resilient health systems for the future. Funded by the UK Health and Social Care, the health program is working to build the strength, resilient health force, and progress towards courage and with sustainable development goal 3.
Incidents. So even during talk about of the knowledge. So now is the truth.
Of stereotyping with discriminating staff students, not knowing it is discriminatory, totally inadequate in the institution, gender family. The global program to Ghana and Nigeria in February 14, and so have closely collaborated with the Ministry of Health and national intervention guide policies in
Very interesting.
So now we can go to our children. the next section of the program. Section of the program is going to be panel discussions and meetings. We are going to produce member panel. We have on the reason and the topic that we have. So each of the panel is going to discuss on a specific theme. We have members of the panel and the moderator, and each team is given and that's no, 45 minutes. Yeah, each team is given 45 minutes. So we are going to invite the team, the panel members now. We want to start with the first panel discussion, and that panel is going to discuss on the retention and the practice, retention and the wedding practice, and that section is going to be moderated by Dr. Oluwiwa at this side. Now the panel members are going to call us up now. For SG41, it's going to be represented by Professor Folashade Omokeljo. Professor Folashade Omokeljo for SG41. Member is representative of LG60. LG is presented by Dr. Kahim Audrey. The next panel is from LG48. And that is represented by Dr. Morenike Alex Ogo. SG48. The next panel member who is representing SG57 is Dr. Abiba Dusumu or Dasumu. I can't say this right very well. Okay, that is LG 47. Thank you very much. Pardon me for not saying the last name clearly. Yeah, welcome. So this group is going to be moderated by Dr. Ojo, and like I said, the theme of their discussion is retention and well-being strategies. Thereafter, there will be questions and answers. So, Dr. Ojo, over to you. I'm sure you.
Good morning, distinguished ladies and gentlemen. As you can see, our panel is gender balanced. Do you want to put your hands together for the panelists? Okay, so some people are protesting, so okay. We have the next few minutes to discuss issues around retention, but first let me welcome the distinguished from the prof left and the other members of the panel. We have discussed the challenges of human resources for health in Nigeria. The best way we've talked about it is the shortage. But the shortage is the global picture. We have more serious issues around the retention, the production, adequate number of work to meet the local needs, the issues around migration, which has become, and retention, the well-being, and the performance of different health partnerships that have implemented different programs or what they can learn from them, and we can scale some of them up going forward. I have about just we'll come back. I would like to start from the extreme right. If that's with the prof teacher. Satisfied in your work, and to what extent has your consortium improved the motivation, well-being, retention, and health workforce strategy? What has worked with us? What are the lessons learned? What has not worked? And what are the lessons we can learn from it? Do you want me to repeat it?
Yes.
Okay. Okay, so if you can have some silence, please. Thank you. What were the gaps or the problems? Can you hear? No. Okay. What were the gaps in the past extent have you, the health partnership, your intervention improve the motivation, well-being, retention, and health workforce strategies, and has worked well with these interventions? If what has not worked well also, what are the lessons you've learned? So we're talking about how you've built capacity, how you've done it, how did your work impact on well-being of health workers, how has it improved their motivation, performance in any way? What has worked? What has not worked? What were the challenges?
Thank you very much. My name is Habibat Daramusu. I'm an ophthalmologist with National Hospital, Abuja. I have a special interest in glaucoma management with the assisted surgery. And in addition, there's also been a guideline rolled out in partnership with the Federal Ministry of Health. My program is building for me because the glaucoma toolkit is a standardized protocol in the management. So from this, I've been able to the residents up to efficiency generally. It has improved their knowledge and confidence in management of our patients. Generally, most of these residents tend to be a bit, there used to be some the DAS protocol and toolkit. I've been able to cascade this down, and there's been a degree of uniformity in approaching these patients. This has helped the residents in gaining confidence. And in addition as well, there was a GLASS training, which is a glaucoma assisted surgery training. This was a program where we had resource persons across the country we had parts across the country and out the country. They've helped us to share ideas. They've given us in management, in the sense that a lot of ophthalmologists are reluctant in taking glaucoma cases as a surgical method. But with this training, it has helped demystify it. It has given us and which management. Twice, this has also been cascaded down to residents, and even some of our nurses from the glaucoma it have a section of it where we talk about competence training. You know, okay, as an optometrist, you can do as much as this. As an ophthalmic nurse, yes, you can do this much. So all this has we've gained knowledge, we've gained more efficiency in managing our patients. So these across board, across doctors, across nurses, and even the optometrists, we've been able to be a bit more efficient. This has overall increased their confidence.
The motivation of health workers themselves to continue to offer quality services to the patients.
Thank you very much. They told them that they can do this. It's part of their line of work. There's an increase in their motivation. Even the younger doctors who before that may have an overlap in some challenges in the diagnosis, it's a standardized way now. So there's an increased motivation, more willing to approach this in a better manner.
Okay, thank you so much. Can we? Dr. Alex Soko, you want to also talk about your piece of work has also impacted on motivation, the well-being, and things like that for health workers. The background of your work, and then talk about the question. The other one.
carried out, as it appears almost the program at this time borders more on force, whether it's motivation, retention, and the likes. Of course, a number of the things that have been talked about affect the motivations, because another aspect of what we're doing is a scoping review of the works that have been done, particularly in sub-Saharan Africa, in relationship to what's been done in the world. And of course, what we've seen, like you said, is the things that borders on motivation, retention. There is an overlap and interplay, and some of it also affects migration in and out variously. You know that Ministry of Health recently launched a national policy on migration of health workers. So some of the content of that study of that document seem to have looked into these aspects, and essentially those things that facilitate all of this can be either financial or non-financial. And I think you highlighted some of them, so I would want to stop at this level.
Yes, I'll come back to you. I think yours and Prof's work, they are very similar. So Professor Shade Omokodion from College of Medicine, University of Ibadan, and the consortium also have the Society of Medicine. And then please, you give us a brief overview of your work and continue from where you stopped. How do you see well-being helping us with retention, with performance, with services? What are the things you've seen already, and how do you think we can use this to improve our policies?
Thank you very much, Dr. Ojo, for having me on this panel. My work is on occupational health. I'm an occupational physician by training, and we focus on workers. My colleagues work in industries, and we look at workers in industries. This is the health sector is a service industry, and we focus on healthcare workers in this industry. The peculiarity of our project is that we increase the capacity of workers to protect themselves, to look after themselves, to fend for themselves, to make themselves fit for purpose. There are many training programs that improve their capacity to treat patients, but our project was to improve their capacity to look after themselves. During the time of COVID, we all saw how were vulnerable, either being infected, burnt out, health issues, and people said
because no support for them. Our project provides this support for the healthcare worker to help them to access protective equipment, to help them to gain knowledge as to what they can do for themselves. Over there, right from 1989, we had the epidemic in the Southwest. We lost a number of healthcare workers. It's been a passion for us, and Society of Occupational Medicine in the UK also looks after doctors and to improve their mental health and well-being so that they continue to work. What we did in our project, we looked at frontline healthcare workers, primary healthcare, and resident doctors in UCH. And we looked at them, we did a baseline survey, and our interview was a 4-day training workshop. We had an in-person 4-day training workshop that spanned 322 healthcare workers, 261 from primary healthcare and 61 from tertiary level. And we put them in for the workshop. We trained them on how to recognize hazards in their workplaces so that they will to reduce the disease that in the world to go back home. psychosocial well-being. During the intervention, we brought in well-being, whether it is psychosocial well-being, whether it is mental well-being, occupational well-being, through the whole gamut. People share experiences during the workshop.
Are generally, but I've had colleagues who are leaving residency training because of the, amount of work. It's already a rigorous, intense program in itself. With the shortage and so many other things, we are drop out from the residency program. We're having some health workers actually also dying, dropping dead, and this. We are not talking so much about it. We need to do something about it. This leads me to the second question. Starting from you, Prof. From what you've seen now, how do you think we can scale up some of this work in terms of development of guidelines, policies, changing our programs, the residency program, even for other health workers? How can we do better? How can we move from research done and everything into policies, into the tools, and changing things for the country?
Thank you very much. WHO already recognized this. They have put in a program, occupational health for healthcare workers. Our project worked with program officer in Geneva, and there's already a kind of guideline, a template that can be developed for each country. In fact, I have discussed with the Oyo State Primary Healthcare Board that we intend to develop guidelines for how occupational health be practiced in the healthcare workforce. We want to start this with Oyo State, and we are hoping that we can actually scale it up to national. I've said in my report that we need the support from the Federal Ministry of Health for them to recognize that there is a problem in not supporting healthcare workers' health and safety and well-being. They did a bit of that during COVID, but post-COVID, people are not providing safety, they're not providing safety equipment, and there's no support system. Like I said, there should be somebody designated. We have just this in our own teaching hospital. We should have designated persons who are looking after resident doctors' welfare, health, safety, well-being, and wealth. Somebody they can run to. But we are also training the resident doctors themselves that they should look out for each other. This is so important, that you look out for each other. See who's faltering, see who is becoming reclusive, see who is being absent. There's a reason for every action that people take, and you need to find out what that reason is so that you truly help them. So in terms of policy, there's a template. But the problem about policy, because I have experience with policy in the College of Medicine, you put a policy down and it just sits on a shelf. So we have to go from a position where we have a policy that works, that is implemented. And I've told the Oyo State Primary Healthcare Board that our policy with his board, we're going to use that as a test case to see that we implement that having a desk officer or a program officer for that particular program is what we're going to use as our template to ensure that this takes off. If this works in Oyo State, we can move on to expand it to the rest of the country. Thank you very much.
Thank you. Because of our time, I'll say that you have all the people you need in this room. We have the registrar, MDCN, we have the national postgraduates, we have director, I've seen the DPRS here, somebody from public health is also here. So it will be very important to take this up at national level. It will be impacts for the country. Then you can support your states to really see how that goes. Because of our time, I would like to go to Dr. Daramosu. You have worked on scaling up the glaucoma training and things like that, the surgical aspect of it, into a guideline. So what has been the experience of that? As that gain was able to transform all services before. I've seen work on glaucoma, great work. I have people that were affected by this condition, that were given the right to it. I think it's something commendable. The work on well-being, this has been one of my RI, and unfortunately we've not given the due attention to caring for the carers. And you mentioned about how one of the trigger for migration, I read a paper years ago, was how health workers in some developed countries were dropping their work because they were after COVID-19, and they need to jobs, and they brought in more people from Africa and other countries. Great work that you're doing. I think what we've failed to do sometimes is this beautiful work from academia, from this how translate them to and those policies are now being implemented. An area, I hope that in the next phase, do something about it to transform this evidence into policy, and we begin to see the impact over time. But thank you so much. I think we've had great take-homes. Occupational medicine is very important. It needs to be instituted. All our major hospitals, all our major ministries of health need to do something about it. Margaret wants to say something. 30 seconds.
Thank you. I'm Irish.
Okay.
Thank you so much for the wonderful presentation and this aspect of workforce strengthening around all the intervention lead to better practices. I've seen already there's impact. Maybe a question to the federal ministry and state ministry representatives here about what have they heard today that they think could be scaled up and could be sustained through efforts at state and thank you.
So that question, I'm hoping that other questions, Federal Ministry of Health, we have the chief of your state's healthcare board from the states. We have DPS here, Dr. Camille Chirete. What can be scaled up also at national level. I'm tempted to go on, but the plan brought up two times. So I want to stop here by thanking the panelists, professor, and everyone. Everyone, let me mention. Thank you so much for your as they return to their seats.
Thank you, sir.
Thank you very much, our great panelists and chair. Thank you for utilizing the time very well.
Group photos
Just
for
4 minutes
panelists.
to see how we can make that up.
Group photograph for the panelists before they leave. Please.
There's a group photograph for the panelists. Please, bro, can we please come back again for the group photograph? Please, Madam Adelike, you let us know that before they leave so that we won't send them to go and come. The panelists, can we come back quickly so that we can take group photograph, please?
Sorry.
Yes. The chair. Right. The photographer, please. We time is not a friend now. Right. Okay. Thank you very much. Thank you. Yes. I'm going to move forward now. While we were going to the agenda, there were activities that because we were expecting the people to come. I told that the director, head plan research and statistics, was on his way, but because of exigence of time, he had to attend to another quick meeting, and then after the trying time now, and he came. The panel discussion was going. In our meeting, I to respectfully recognize him, Director Planning, Statistics, Surety, and he to give us even though he has a bit continued, but the time. This is the time that we are open because we kind of back up. So you are welcome, sir.
Excellencies, I can see Dr. Mrs. Saraya, Dr. Okay, representative of Honorable Commissioners here present, various the Department of Health and Policy. My teacher, Professor Shado Mokodion, I saw her, Professor Aki Thank you, sir. Well done. These are my two teachers, so please help me appreciate them. Slogan President, you are recognized, sir. My director, retired but not tired, Dr. Morenike Alexoko. Welcome, ma'am. Thank you for all you've done and all you're still doing. Thank you. Our friends from Global Health Partnership and Matilde, Margaret and Elaine, welcome. Apologies from my coordinating Minister of Health and Social Welfare, Professor. We had an emergency meeting this morning. On my way here, I was called back, and there's a new meeting that this president is attending, so he sent his apologies for not being here, and he's attached great importance to what we are doing here. The World Health WHO Executive Board meeting ended yesterday in Geneva, and topical for the week-long discussion was the emergency situation we found ourselves with respect to the global health workforce. Every country has one challenge or the other in this area, and particularly the worst situation is the African sub-region, and Nigeria, of course. We've heard of the JAPA syndrome, and hopefully we will have JAPADA very soon with what we are putting in place. We have our HRH policy. We also have the health workforce migration policy, which hopefully in the next couple of weeks we will strengthen its implementation and everyone will be involved. I met the panel discussion while I came in, and Professor Dion was calling on the Federal Ministry of Health to help your state to do one thing or the other. We are going to help you. Though I don't know the request. Let the request come, just have the approval that we are going to help you. I'm not too sure whether I should read any speech. Thank everyone for making this possible. Muyiwa and your team, thanks for all you are doing. The UK Department of Health and Social Policy, right? Thank you for the support in making this global health workforce program to do so much. They've gone, and the Federal Ministry of Health and Social Welfare really prioritize this and that's why we launched the migration health workforce migration policy, and we'll still be inviting some of you to the development of the implementation framework, because we need to put it into action. They produce health workers for export. We are into discussion with them. India does the same. So, and at the executive board meeting, we're discussing the health workforce issue. WHO came to Nigeria to say, aren't you going to say something? So we told the world that we are working on this. We want to learn from what the Philippines have done, what India is doing, and several that are helping others. We know about the human experience, and Nigeria should just take a cue and also benefit from the good sides of these programs that is being implemented. And let me especially appreciate the works registrars of our various councils that are doing. I know in the last few months we've made registration as ministry to increase intake into our training institutions so that we increase outputs. And at the same time, this particular budget of 2025 is also focused the capacity of the institutions to be able to absorb this new increase in intake in terms of equipment, the facilities, and also manpower that is needed to train them. So we will still be needing your support and of prayers so that these objectives ourselves are achieved for the benefit of all. Once again, let me thank all the partners that have put this together and are still continuing with the health workforce program. We will be assured that the Federal Ministry of Health is ready and willing to support these current initiatives and new initiatives that can propel us, accelerate the attainment of our objective for this global network as it pertains to Nigeria. So once again, thank you very much. And let me also use this platform to let you know there is a project that is coming up called the HOPE project. There is the HOPE Gov that deals with governance. There is the HOPE Edu that deals with education. And the HOPE Health that concerns us particularly is going to involve massive investment in private development, investment in health workforce, and incentivization or incentivize the subscribe to implementing the whole project to be able to recruit health workers at the primary care level. And also there's a TLI for retention of those workers. So some may start as volunteers when the project starts, and the rate of absorption into areas of deficit will also be rewarded. So this is a project that is coming World Bank Fund going to support the states to implement this, and hopefully by this time next year, I want to thank you for what you are doing, what you've done, and of course, what you are going to be doing from tomorrow. Thank you, thank you, thank you.
Thank you. Please, can we give him a round of applause? Please. With him, we want the THET group, the THET team, with the norms and WHO representative. So His High Excellency Dr. Mrs. Saraki, those ones in front there, please do a group picture with him. And I want to also invite Dr. Director of Public Health, who has come in to join in this group picture because he is representing the Honorable Minister of State. So he is helping us now. Like as the director said, all of these are going on, so they are jumping from the order. So that's why he's coming in now. So please, we'll just quickly take the group picture while. Thank you very much. Thank you. Thank you. Right. So, right. Okay. All right. So we are going to move quickly now to the second phase of the panel discussion. We're going to move second phase of the panel discussion with the theme improving leadership and management capacity of health workforce, including mentorship, with the particular consideration of gender equity and social inclusion, the JCB. That will be the panel 2 discussion, and that is going to be moderated by Dr. Wakego Chukwuka Odinaka. She is the moderator of the second panel discussion. And of the panel are representative of the LG83, Dr. Fatima Adamu. Dr. Fatima Adamu. Now, the representative of LG116, Professor Abdurrashid Ibrahim. Professor Abdurrashid Ibrahim. Representative of LG59, Dr. Sam O. Please sit as you come. This is the moderator's seat. So, yes, I go. High table. Now, of G95, in the person of Abuja. LG95, already here with me. In fact, if the photographer is close by, I can take us a picture. It looks like. The moderator, you have the microphone by your side, and the time allocated to you is 45 minutes. And the time now is 23. That will be 48. Yeah. Yeah, so 45 minutes. I'm trying to look at that. Yes, 48, because we have 5 minutes into your time. So please, your time starts now. Thank you very much.
So, thank you. For this panel discussion, we are going to be looking at improving leadership and management capacity in the health workforce, with a particular attention to gender equity and social inclusion. So, in the process of selecting the guarantees, we actually looked not only building capacity, but how can we improve the leadership and mentor, so that there will be room for sustainability. And so, some of the things that we looked at and we consider that area of leadership is coaching, collaborative engagement. At the JC, we talked about gender mainstreaming, women empowerment, community agents, and the responsive care. So these are some of the things we felt it's important if we're going to look at how to ensure that what improves beyond the and I want to ask them, probably I will start from my girls. So, what was our problem? Identify the competence and what has worked
changes. Thank you very much. I'm for our party. National Women Empowerment Initiative, medical in UK, Council of Nigeria. Our really about digitalizing the teaching and learning of colleges of nursing and midwifery, and we start two areas. One is the production and the use of digital resource. How we can make teaching and learning interactive, because it's producing, creating videos, teachers creating videos. And then the second one is the integrating all of this, integrating gender equity and social inclusion into the education. So, of course, when we started, we started with the management. Anything Jesse, it has to start with the management. So we invited the management and we had a series of training. Doing it small guys, a lot of that was followed by they went back, the management of the college, they went back, scale it up with other engagement, and also sensitize the student. We went into the coaching and monitoring visits to give them the technical support the management needs. They have developed an action plan. Based on that, they move on and we supported them. And also one of the training we did was to support them to identify who are the vulnerable groups that are at risk. And these are both students and staff. So we were surprised with the young lecturers, how vulnerable they are. We thought the vulnerability is more with the students, but we found out also young lecturers were really vulnerable. So, what were the things, what were some of the outcomes? We were surprised with the result we've seen. One of them was there were a lot of establishment of JC structures in the colleges. We worked in 7 colleges across the country: Akwa Ibom, Kano, Mina, Sokoto, and Ibadan, UCH Ibadan. And so we set up a lot of structures. And another thing, based on that, they also integrated in some policies, especially the student handbook, addressing, giving them some voices, how they should report cases of any form of harassment, and changing their admission policy, for example. It's one of the things we confronted when we introduced the issue of JC. For them, why should they, nursing is a very rigid profession, nursing and midwifery. They see no reason why they should admit somebody leaping and somebody was minor disability. And if they perform academically, they come for interview, they find a way to exclude them. So all of this, and that was all addressed. And again, after that, they really implemented quite a lot of, because there are so many exclusion issues. Is it based on religion? Is it based on value? We found all of this among the students. And so married students were facing a lot of challenges. Many colleges, for example, at least 3 had established crèche for their married students, because they have many of them unmarried. And we have also some of them. Also, I mentioned the issue of admission slot. So now they open up their admission, and about 4 colleges have now admitted in current admission. They have admitted, and we have some of them here admitted with those with some minor ability. The argument we did, we said, look, you are a training institution, not an employment institution. So why should we discriminate against that? So that was also we also, for example, in clinical science, in some states, let's say in Abia, for example, I said in some states, male, even though they have male midwives, but yet they are not allowed into the labor room, for example. And we said, what? So now they engage with the clinical sites, and now they are allowed to go into the clinical side. And many of the management, they took the JC message up to the clinical side, because some with the health conditions suffer a lot, and that was resolved. So the colleges, for example, have taken all the issue of those with health condition, engage with them, and we have so many those that are harassed, discriminated, and they are giving the voices. I know I'm trying to rush. And one interesting thing was the way in which women, female students, hardly contest for leadership, president of the student union government. That has also, we encouraged the student, and we have at least 2 colleges that women contested for president of the NUC. So this was some of a lot of outcomes which I cannot, but we have some lessons learned. Maybe it's something the next round we can't discuss, but we've learned a lot of lessons, and that we really like to share here. Thank you.
Okay. Dr. Ibrahim, yes, we are talking about multidisciplinary. I knew that probably during the training, when we were talking about the tumor board, it's restricted to the doctors, but from the experience that he has, he can tell us more on that.
It's a huge background. Of breast cancer is in Nigeria. Early is reaching over to 184%. Among the is included tragic narrative that is familiar, that everybody is as a result of multiple factors, including the fact there's limited access to detection and diagnosis centers, and then of course you also have significant problem with patient education. Most of patients are aware of what you need to go to, and this is compounded the fact that we have limited for breast cancer, and the crucial gap that we picked up even among the multidisciplinary team, which is the backbone of quality breast cancer. What we did was to put up an intervention. That's the exciting part. We know it is possible to identify gaps, but the huge problem is we identify the gaps. How do you implement? I think the first group of panelists also talked about that. Ideas or having solutions to the problem. We thought we will reach on an implementation system model to see how we can identify problems and then create interventions that will solve the problem. And key to this is what she has just here, President of this panel has got. The unique difference with the breast cancer health workforce is we're used to working in professional silos. So as radiologist, oncologist, or a surgeon, residency training just stay always at your local institutions or conferences you work. So what is exciting here is we're able to create a resource for interspecialty training and education, and we'll brought to the same round table, if you like, the pathologist, the radiologist, the oncologist. And the first step was actually to get a Google form What attitude skills, what competences do you think will be beneficial? You have an MDT. So we had to fit it into the context of Nigeria. MDTs are everywhere, but the problem is in the African context, given our unique it was fit for purpose. The next thing we now did is we looked for barriers and facilitators to interspecialty training and education. What are those unique things in the West African sub-region? Quickly add that this study was done in 3 institutions in Nigeria: UCH, Badon Hospital, and ABU Zaria. And then we also did Latin, Lebu Digital in Accra, and KHTH. We had some astonishing results to share with everybody. As a result of this intervention, which is some, of course it is also in the public domain, some institutions don't establish MDT. Some have an MDT, but they're struggling to get it right. And then some institutions have started, but they've not also made much progress. So what we did is, first of all, to create leadership and using a spoke and hub model. So in each of these institutions, we identified what we call bright champions, and they will be in charge of those MDTs, those breast cancer MDTs in these institutions. They will also subsequently spread this good word, if you like, or this attitude of making sure every breast cancer patient or breast cancer patient has with multidisciplinary team care. That we also ensure the coordinators, say, had access to the coordinators in the area and the internal to the coordinators in Abuja. We did it level, stepped it up to a level, and then we're now going national as well. There is going to be training and retraining that will go on, and the icing on the cake is all. We were able to 20 of these key leaders, these champions from each of these 5 institutions, and they went some 8 weeks training in the UK. They actually participated in the breast cancer MDTs in the 4 institutions in the UK, and we think that's just we'll all come back now and then share the experiences. How do we manage to bring and the second, it is a African culture that but happily I can see the VC being heard. If you look at the admission across medical schools, time was you see a sprinkling of female medical students, or I dare say female nurses too. But just ago, I was to have a new set of 400 level students, and it's quite impressive. Number of female admission is increasing. So that equal representation is made to make an so to speak, and especially since most patients with breast milk, I think is appropriate. It will also be nice to share with you that the resource persons that we invited from the UK were carefully hand selected, and most of the volunteers out of, I think, 11 of them were all actually female. How to make sure this leadership at the Jesse that we have been able to develop so far is also stepped down, and then of course is sustainable. I'm happy to announce to you that we're hoping to spread it around. We've done 3 geopolitical zones in Nigeria. We're also hoping we can we can cascade this down to zone, and if indeed the rest of the top turn after. So one of the questions I'll take as well.
Okay, thank you, Dr. Ibrahim. Professor Sam, we've been looking for a way between the 2 colleges, the Royal College and the I think this has now proved, this grant provided one of such opportunities where we intend to raise leaders that will help to cascade things down. Can we hear how you did it?
Thank you very much, moderator. I'm at the UK for Global Nigeria, working on this program. Our partners here are the Society of Nigeria, Sogon, and
the African Center for Excellence for Population in Bayero University, Kano. So, our objective at improving women's health, increasing access to high-quality gynecological services through advocacy training, and we cut across the three main areas: make sure that we are gender-sensitive, also clinically imparting skills, and also non-clinical leadership. So, how did we do that, and what was the gap that we identified? First of all, I think we need to acknowledge that we have seen significant progress in prioritization of health over the last 30 years, especially in the area of maternal and health. However, most of us will agree that problems has not had the same success. Indeed, across both nationally and internationally, policy research and health programming has been a little bit in the back burner in terms of gynecological problems. And yet, we know that gynecological conditions are very important and have large impact on female health and what they achieve over their lifetime. Most of them are life-changing, and funding in this area will be forthcoming, as we've experienced with obstetrics services. However, that is what we aim to identify, and we are using a training package which was developed by the Royal College of Obstetricians and Gynecologists, the Essential Gynecology Skills Training Program, to address this situation. So, what we have achieved so far, working with the partners here, first of all, we had to review the training packages to make sure it's in the context of Nigeria. So that was the first thing we did, working through Sogon and our partners in ASEP. So we got that, and the first thing we did was to train expert trainers, a cohort of 20 expert trainers, in fact 11 females and 9 males. So you can see we are sensitive in that area. So we were able now to cascade down training to frontline staff in Kano and FFCT here. And over 180 of frontline staff, equipping them with the skills to be able to recognize most gynecological problems. At least treat the ones they can treat on site, and then make sure they refer those they cannot. So we've following some 36 champions in the different facilities, and we've created an online training package for them in leadership training so that it will be sustainable going forward. So that's where we are now, and the greatest achievement as well is that we had a wonderful buy-in from the Federal Ministry of Health, and they have validated the training program and are at the point of cascading it down to the entire nation. So I'll take more questions later. Thank you.
Your work is slightly different from all the others because we've looked at human resource for health, which is one of the major challenges that we have, and your work you focus on improving it's doing. So I want to ask, from your experience, has it gained national support, and what policy change, what you're doing? Just a brief introduction of what you did and how it has influenced policy change in the areas where you work.
Thank you very much. I think just that I represent the Clinton Health Access Initiative, and our project partners, the London School of Hygiene and Tropical Medicine. Back to your question, our project really addresses 3 to 4 fundamental HRH problems that are very popular but very to address, right? The first is really the issue of inequitable distribution, right? The second is a review of weak productivity and performance of health workforce, especially at the rural communities. The third is the issue of coordination or governance capacity at the state level. And the fourth really is that it is the JC issues where you see frontline primary healthcare workers having very weak capacity to be able to deliver respectful maternity care. So on the first one, which is around the problem with inequitable distribution of workers, how we address or coming towards addressing the problem is threefold, right? First is really supporting the development of tools. The tool which is really, providing evidence base to guide evidence-based and equitable distribution of health workforce. And that's where we did what we think is a remarkable work of customizing the National Primary Healthcare Information System into a HRH information system, changing it from just a mere data repository to a customized information system that health workers or health managers at the state and government level can use to cost and workers. So on the two aspects of it, on the process, we supported with the development of guidelines, right? So one is to say this is the what do you call it? The help equitably or evidently postures. How do you do it, right? Development of guidance and processes to support PS every post health workers them where most needed. Firstly is like that management past workers or PSC managers across to be about guideline and the two course that I have. This front is, like I said, improving performance and productivity of health workers that are located in rural areas. What we have done is also along those lines. Number one is in defining or developing a comprehensive approach framework for guiding how primary health workers' performance and productivity is measured and improved, right? Which also follows with strong and comprehensive capacity building of from the states to the local government and the health person level. But just because I know we are pressed for time, but in terms of some of these practices or policies that we have developed have been adopted, I'm happy to inform you that the information system that we have worked to customize is now available for use by any right? And it has been adopted by all the 2 states that we've worked with and is available for adoption across the country. The second, in terms of the guidelines we've developed for guide how can be improved within PHC workers. All of those guidelines and practices have also been embedded within the HRH policies of our state. And I think one critical thing, which is a very positive note of time, is the for example, with the performance and productivity framework that we've developed. Ondo State government, a particular local government in the state had already adopted our framework for measuring and improving performance to use it as a basis for, providing or giving award or recognition of health workers. But using the framework that we've supported them to develop to measure the performance of health workers and use the findings to even goal is to reward performance. But I think I will pause here. Thank you.
Okay. Thank you very much. So Dr. Fatima, in 1 minute, just tell us the impact of your work in police in helping to shaping the policy for the nurses, as well as how the changes that were noted following your impact.
Okay, thank you very much. In 1 minute. Okay. One is actually, since Nursing and Midwifery Council is a partner, we are working with the Nursing and Midwifery Council. We have a draft because all the one guidance from the Nursing and Midwifery Council, and we're working with them on that. So, which will have wider action across the over 300 colleges of nursing that we have across the country. In terms of technology that we did, installing a training, I believe, and the last one was with the students. The students were more interested in the technology than lecturers, and the way in which, in fact, we have in 2 schools, I think it was the students learn developing videos and sharing it with others. Now they want to in the server that we produce for the lecture, they set section so that they can be teaching and what I'm going to do is the lessons we learned was between the north and the south. Interestingly, in the south, more female was than 90% of those we train, across we train, they were female. Only 30% were female for the north. Interestingly, lastly, was the cost of the program. Where it is high, the cost of training nurses very high in the north. But yet you have only financial support in the north through the government allowances and none in the south. So there are a lot of differences, also differences. I thought the lessons learned, I will have time to do that, but obviously, no time. Thank you.
So, Prof, I don't from the multidisciplinary aspect of it, how has that turned into policy? Have you been able to make sure that it is incorporated either in the training, or the colleges are absorbing it, or is it that the health facilities are now, embracing it as a way to go?
Yes, thank you very much. I think we had a stroke of serendipity in the sense that shortly after the launch event in February last year, the Federal Ministry of Health has now made it mandatory that for all patients, and it's not just breast cancer, for all patients who have oncological, who have cancer, they should have the opportunity to have access to a multidisciplinary treatment plan. So I think all tertiary institutions, and I dare say all hospitals, are now mandated to do that. So that has really come at a super good time for us. So it is easy for us to engage with the MDs and the head of institutions and say this is the policy statement for the Federal Ministry of Health. We know we have huge numbers of times patients who have breast cancer. So what we're able to pass across, and I think we can put other cancer, including prostate cancer, cervical cancer, is yes, because each number you may not have an MC on those patients, but you can also flag them. Patients have breast cancer at young age, breast cancer in pregnancy, family history of breast cancer. You can start with those ones. And we got this idea actually from engaging with the UK team, and that's actually what they did. Now, by the time you improve and then you get better with the organization of the services, I'm sure you also have more patients benefiting from it. But I think my strong takeaway point from it is, while it is very good to have a policy stamp for the Ministry of Health, what is also important is the attitudinal one from we, the healthcare workers itself. I think that lingers longer than any policy, that we accept that this is not just a policy on paper, but it is giving quality care. And quality improvement will be seen the watchword, not just in breast cancer, but in every other service that we render. Such that for us, what we, in terms of leadership is, we brought in residents into this course as well. So while we had consultants at the lead, we also made sure our residents who go to future leaders were also in the hall, including training nurses as well. Yeah, thank you very much.
Okay, so Professor Sam, finally, now I know you were engaging with the Federal Ministry of Health, so where are you people in the area of incorporating into the my maternal care policies?
Sure. Yeah, we had a very good engagement with the federal ministry. We went through a validation process with experts who sat with me and went through all the training manual page by page, and we agreed on what should happen in night. And I think my understanding is that the coordinating minister has signed it off. We are waiting, because I've seen the acknowledgement he wrote on that, and we are just awaiting a launching date, which will be very soon. Okay, but in terms of impact, what we did as part of our monitoring and evaluation was that we organized a supportive supervision in the facilities, and the feedback we got from there was excellent. The practice we taught them were already happening on ground. Okay. During that supportive supervision, we identified some few gaps, and then followed it up with a refresher training, which has embedded the skills we sent to them. Again, the feedback is very excellent. Working on it, we'll be sharing it with the people. So that's where we are now. Thank you.
Okay, thank you. The panelists, I don't know, maybe we can just entertain one or two questions because we are short of time. Any question? Okay, Dr. Joe.
It's a sign how fantastic the panel was. I think it was really rich. A lot of it. Someone had one? Oh, I didn't see.
Thank you so much. I hope you permit me to sit. My question is to the Prof on the multidisciplinary team, especially for breast cancer. Are there challenges in bringing different, especially I can understand simple, the same cadre, but bringing different healthcare workers to get issues of health in you're doing, and what is needed to scale this up across the country. Is it something? Is there a template that we can use to replicate this rapidly across the country? And what has been the feedback in terms of the health workers themselves? What has been their feedback? Were there eureka moments for some of them, seeing this collaboration, how it has improved the quality of care they provide to patients themselves?
Super, thank you very much indeed. Yes. In the context of Sub-Saharan Africa region, Sub-Saharan Africa, that's Ghana, Nigeria, what is unique is its hierarchy is extremely important. So it's a culture where older, degree of acknowledgement. So we totally agree with that. We say you acknowledge the hierarchy, that the boss is there, he's been holding your hand and guiding you. But when it now comes to the management of breast cancer patient, we leverage this. So that has been the huge challenge. Today, you can actually speak with respect and acknowledge, yes, the boss is right, but regarding this patient's diagnosis and treatment moving forward, as a pathologist, as a radiologist, oncologist, what will guide us from now on is the evidence that's therein. And it was, of course, we had challenges with that at the beginning, where people actually will step back and not want to contest or a particular case, as we all know, those are familiar in medicine. But that has been well taken care of. I think the faculty from the UK that came, despite different contexts, but the key aspect was one aspect that had to do with knowledge and skills, and then more importantly, attitude, which is leadership skills, which had to do with leadership, which had to do with mentoring as well. So I think that really resonated with faculty and it became easier to take. As you'll see, that have been in the academics for a while, the environment that you see now in terms of training compared to what it was a couple of decades is quite changing, and I think that shift is absolutely fantastic for what we're doing as well. I think the key challenges that we had was getting people out of their busy schedule to come and attend the meeting, and this also replicates in real. So you have the pathologist, the radiologist, the surgeon to have time to come for an MDT. So we have to get leverage of technology and such that a lot of them are doing physical meetings and by beginning to do leverage on Zoom. So after 8 p.m. on a particular day, when you can have a good presentation, because you must have adequate representation from each of these specialties for you to make the decision. Moving forward, I think I left it. Thank you for bringing it up. In addition to the policy formulation by the Federal Ministry of Health, I think our colleges draw from experience that says institutions or tertiary institutions have to have mandatory accreditation periodically to say you're fit to offer surgery, postgraduate, or ONG as the case may be. So we're beginning to think that that's a policy push we suggest to both the West African College and National Medical College. Can we have accreditation status that also emphasizes the fact that institutions that have MDT for oncological services, not just breast cancer, will also be acknowledged that it becomes mandatory. I think it would be one easy way, in my opinion, to make some progress forward. Yeah. Thank you very much.
Okay. Thank you, Prof. Actually, I was at one of their meetings and I saw that the nurses were involved, the pharmacists were involved, the resident doctors were involved, as well as the pathologists, the radio-oncologists, and all the others. So I think it's more. Thank you. And I want to panelists.
Thank you very much. Thank you. Before I want three representatives: the director, Plan Research and Statistics, Niger State, the Executive Secretary, Board, the Oyo State, and that Honorable Commissioner for Health, Kano State. We just want you to respond to this panel discussion on how it has impacted your state and what do you think, what do you have on the ground to scale up the activities and ensure sustainability. So please, I can see the director from Niger State. There. Please, can somebody give him a microphone? He can speak from there. Niger State. Then the Executive Secretary of your state, and that of Kano, Commissioner Kano State. Can somebody extend the microphone to him? All right. Just tell us the plan you have for sustainability.
All right, very much. Dr. Ino Ajunedu. I'm the Director of Plan Research and Statistics with Ministry of Public Health. I think Yerima has said a lot about what happened. It's across the across. I think the first thing is the human resource for health information system, and then the other one is policy guideline. And I think so. Over the years, I think those documents are embedded within the civil service. But hardly those primary healthcare workers, especially, take time to understand that. So I think what this does is that all those documents were brought in together and then we review. And so the managers, the PSC managers, that is the local government PSC director, are now better equipped with the human resource for health and then the process and procedure for deployment and redeployment. I think this is one of the key things we have, and their capacity has been built towards that. And then the second thing is the human resource information system. To us, I think even when they came, one of the things we keep on telling them is when you're coming to state, we do not want to have the past experience whereby you come in, develop a document, and then you go in, you go with your document. So there has to be some element of sustainability embedded in that. So I think from start to finish, even people that piloted the project are people from the state. I think the boy that developed the human resource for health information system is in my state. And it's working with the MIE to update it every 6 months. So I think it's one of the key sustainability we put in place. Now the second one is the guideline, human resource guideline for deployment and redeployment. And so this document, what we did at the start of that document, we didn't just allow it to be restricted within the Ministry of Primary Healthcare or health sector, because we know that some element of administration that comes in from the Office of Service. I think one of the key things we've done was to ensure they participated. There is people that are coming from that arm and they will sat down together and develop that document. So I think to meet these critical responsibilities, and then we're beginning to see how we can scale it to cover the state. Thank you.
Thank you very much. Thank you very much. Thank you. Do we have the Honorable Commissioner for Health in Kano State? All right, sir. Yes, we just wanted to share the sustainability plan with you.
Okay.
Thank you.
Good afternoon, all. My name is Dr. Shehu Abdullahi, Director of Medical and Healthcare Services, Ministry of Health. As presented, you know, Kano State Ministry has been collaborating with various organizations, especially in Bahrain University, Kano. We have been conducting a lot of collaboration with the ASEPAP Center. We were fully involved in what has been presented. Actually, it's a training of frontline healthcare workers. About 90 of them were trained. Health facilities, Sanusi General Hospital, and the other one is PHC on this essential gynecological skill. We want the Ministry of Health has already made it fully. Whenever such mention is being conducted in the state with the full participation in the state like this one, or has made mandatory that in our facilities. What is we will look at the training and make sure it is in our facilities. That's all.
Thank you very much, Director of Kano State. Thank you very much. Thank you. So I just got to know that the Secretary of State is on the board. We are going to go straight now. The panelists, I want to thank you all for all your questions and the insight you've shared with us. So we'll go down now and take a photograph with the photographer, please. So let's go now, take a photograph, and we'll take the next point on the agenda. Thank you. Please, I will be there on behalf of this. Thank you. Please, let's take the photograph. The panel members, the chair, the moderator, Thank you. Are we ready? All right. Please. Okay. One more. That's all right. Thank you very much. Thank you. Thank you. So, yes, before we go to the next panel discussion, which is the panel discussion about trade, I want to use this opportunity to recognize and welcome the representative of the Honorable Minister of State, Federal Minister of Health and Social Welfare. Remember that I mentioned it before, we say because of the case we're having in the ministry, we're going to speak with identify people and we call them all. So the representative of the Honorable Minister of State, Honorable Dr. Isaac Arikis is Dr. Godwin Tado, who is the Director of Public Health in the Federal Ministry of Health and Social Welfare. So he is able representing the Honorable Minister of State. He is going to give us a short message on behalf of the Honorable Minister. Director, sir, you are welcome.
Good afternoon, everyone. I wouldn't know if any protocol was established at the beginning of this meeting. Permit me to stand on the existing one. I also want to acknowledge the presence of my predecessor when the former Director of Public Health is also present here, Dr. Alex Oku. Thank you very much. Unfortunately, the Minister of State was unable to come for this meeting. Though he would have wanted to be here physically, but he has asked me to come and represent him, and he sends his wishes, his good wishes. Permit me to do already asked to present here. It is my pleasure to welcome you to this Global Health Workforce Program and sharing event for health workforce in Nigeria. I am honored to deliver this goodwill message today as we mark the significant progress we have made in strengthening the health workforce in Nigeria through the Global Health Workforce Program and to explore strategies to sustainability. I would like to express our sincere gratitude to the primary funder of this program, the UK Department of Health and Social Care, first for selecting Nigeria to be one of 3 African countries to be part of this program, and for their unwavering support and commitment to the successful implementation of this program, for which we are here to learn and share experiences today. I also extend our appreciation to the Nigerian implementing partners, Ducit Blue Solutions, and all staff of the Federal Ministry of Health and Social Welfare for their tireless effort in making this program a success. The Global Health Workforce Program, no doubt, has greatly contributed in addressing critical health workforce challenges facing Nigeria. Through this program, we have recorded commendable achievements and significant progress in improving the quality of health care workers through learning and strengthening the health system as a whole. It is instructive to note that the program was developed to align with the human resource for health priorities, and the government further demonstrated her commitment to addressing the human resource challenges by launching the National Policy on Health Workforce Migration last year. The policy is aimed at managing and mitigating the negative effect of the large-scale exodus of health professionals from the country, often referred to as brain drain or Japa syndrome, by offering incentives and improving working conditions to retain health care workers within Nigeria, particularly in the rural areas, and potentially attracting those in the diaspora to return, thereby greatly improving the Nigerian healthcare system. This is just one of several strategies being implemented by the government to tackle the human resource challenges, and while still in its nascent stage, is already yielding some results. As we gather here today to this event, we should not only celebrate our achievements, gains, and successes, we should also share experiences and lessons learned by truthfully identifying our shortcomings, challenges, and remain issues that need addressing and provide workable solutions to guide future interventions. Going forward, we must prioritize sustainability, ensuring that the gains we have made are not only maintained but also promptly built upon. While we commend the typical resilience and dedication of our healthcare workers who have continued to work tirelessly to deliver quality healthcare services to the Nigerian people amidst the numerous well-documented challenges, we must also continue to invest in our healthcare workers, providing them with the remuneration, appropriate training, equipment, security, support, and conducive working environment they need to deliver high-quality healthcare services to our people. Once again, I would like to thank each and every one of you for your immense contributions to the success of Global Health Workforce Program for the last 1 year and for this event. Your hard work, dedication, and commitment to the health and well-being of the Nigerian people are well appreciated and will always be remembered. I wish you all fruitful deliberations and passionately urge us to continue to work together to build a stronger, more resilient health system for Nigeria. Thank you.
Thank you very much. Please, another round of applause for him. Thank you very much, representative of the Honorable Minister of State. Thank you very much. Dr. Kodri Itadon. Thank you very much. Thank you. So, yes, we had a break for us to allow him give the goodwill message representing the Honorable Minister of State. Now we are going to proceed with the next agenda, in line with what we have done before, which is the panel discussion. We have only one panel discussion more to go, and that is panel discussion number 3, which is going to discuss on the theme sustainability of training interventions. Then we have to look at the impact. We have to look at the curriculum development and implementation of the program. I know as people in the health sector and the duration of the program, which is just 1 year, and also like that. So for us now to be thinking, what is the impact? Well, let's look at it to how far we can be able to do that. So on that note, we are going to invite the membership of the Group 3, which is going to be chaired by Dr. Ebere. Group 3 is going to be chaired by Dr. And the membership of the group includes Professor Usman Ali Omar, which is the LG 06. Usman Ali Omar. Thank you, Prof. Then we put there by Dr. B. Dr. Jazz Abi. Thank you very much. And we have a representative of LG 135 going to
to be replied for LG135. They will have SG38, going to be replied by Afolabi Fajemi Law. Yes. Then we have another one again, LG01, going to be by Professor Akande. Thank you very much. So these are the panelists, and Dr. Bere is going to moderate this section, and they are going to discuss on the sustainability again. Yeah, they will reflect on all the things that we've done and the impact. So, Dr. Ebere, you have to deal with, and from my own time, is 13:22, which is 22 minutes after 1. If I add 45 to this, that is will be some few minutes after 2. Okay, baby. Over to you, sir. Thank you.
Thank you very much. Yeah, so good afternoon, everyone. So this session will focus on sustainability and impact. One of the things that we were really interested in when this program was set up was to think about how these grants can lead to change, not just about delivering results or training a certain number of people, but also how it can lead to systemic change in the longer term. And what we're really keen on ensuring that in the way that the grant is delivered and we know we can't achieve all of that in just 1 year, but that you are able to have an implementation system that actually looks towards that. And that's what we want to require, a strong focus on getting government involved, getting the state and federal involved and other agencies as well. So I'd like to do Usman Ali Umar, just to hear a little from you about what your partnership was about, but also what has changed so far. What do you see, the prospects for sustainability or scale up of the intervention which your partnership was focusing on?
Thank you very much. My name is Professor Usman Ali from Bayero University. Other members of our partnerships from University of Ibadan, King's College London, University of Warwick, and University of Ghana. Our research actually looked at a knowledge gap that we identified based on the fallout from COVID-19. We will really understand that there is difficulty in accessing healthcare services. So we looked at ways of remote consultations for primary healthcare workers, where patients with chronic illnesses can access healthcare remote consultations. And this we did in two ways. First of all, we train in-service workers, especially those at the primary healthcare level, how to offer these remote consultations. And then we get final year students from School of Nursing and Midwifery, from medical schools, that is both nursing and medical schools, and from community health extension training schools. So besides those students, final year students, we developed curriculum for integrating this training into the training curriculum of the students. So by the time they come out, they already have the knowledge about remote consultations. Also, one of the things that we offered was collaborating with regulatory bodies like the Medical and Dental Council of Nigeria, the Nursing and Midwifery Councils, and the Community Health Workers professional bodies, so that they can be accredited. The training modules we offer as grants accreditation, so that it can be to gain points for continuous medical education. So these are the two ways that we're able to do. And when we did the training, we were able to train more than 800 healthcare workers, and then we're able to integrate this training and into curriculum for some of the teaching, some of the training institutions that we collaborated with. We opted to so that it will become acceptable nationally. These training modules will be instituted, and students can have the training before they graduated from the medical schools. Thank you.
Thank you very much. Be interested to know, in terms of the trying to foster the sustainability, what challenges did you have, particularly, in engaging with like the bodies or getting your methodology into the curricula? What challenges did you have? How were you able to overcome that?
Yes, when we're conducting the training, we have some initial challenges because the training modules are internet-based. The student have to log onto the net to access the modules, like 7 modules that you will have to undergo. So besides issues of access to data, there will be issue of connectivity, which we're able to overcome those challenges. Those were the first challenges we had. But despite that, we're able to overcome those challenges. Then with the regulatory bodies, we wrote to regulatory bodies, we submit our curriculum to them. It took a little bit sometimes before we got the feedback, but in the long run, the feedbacks were positive, and we are given the go-ahead. So those were accredited as CME-based training that other health workers can use in order to renew their access and so on. So these were the mainly challenges that we had in terms of the acceptability of the training modules. Thank you.
Okay, sorry, another follow-up. So in terms of going forward, what would you propose or recommend, in order to sustain this or expand this beyond, the areas where you worked? Recommend to maybe the ministries of health or the government agencies?
Yes, in terms of the beauty, we worked closely with our state governors. Like in my state, we had commitments from the policy makers that of commitment to maintain or scale down the training to involve other healthcare workers. The ministry promised to provide a budget line in their next submission so that there will be continued training of healthcare workers on remote consultations. This is one of the major achievements that we are able to achieve during the training. And then when we work closely with our training institutions, in order to make sure that the training curriculum are put into training modules for so we have acceptability in all through the regulate all the universities. That will also go a long way in really bringing out the needs and how to conduct safely remote consultations for primary for chronic illnesses. Thank you.
Thank you very much. Okay, so moving on to Dr. Charles Ame. Can you tell us a bit about your partnership, what you set out
what you were able to achieve. What challenges did you have in terms of sustainability? What lessons you learned, and like recommendations going forward? Thank you.
Thank you. Thanks a lot. So I am from School of Tropical Medicine, where I'm a professor of health, training obstetrics here, and I'm quite happy to be reunited again. Now, the mic is quite epileptic. This is better. Now, in our partnership, we are working with the Wellbeing Foundation Africa, as well as the National Postgraduate Medical College of Nigeria, the Faculty of Obstetrics and Gynecology. And I'll just say a bit more about the faculty. So they have a responsibility to set the curricula for training obstetric residents to become consultants. And this will include running revision courses, examination to get the certification, and this is done through the teaching hospitals all around the country. Sometime 2 years ago, I did some teaching at the
faculty chairman came to observe what was going on, and then we had a side
discussion, and he said
there's a need to increase the skills in terms of advanced obstetric surgical skills within the curriculum. And we agreed that
once we have the opportunity, we're going to put in a proposal, and that's how this grant was written. Now, what we did was to introduce this content, which is actually based on some work that came out from the Confidential Inquiry to Maternal Deaths in Kenya. We developed the curriculum there, and then we tested it at University of Ilorin Teaching Hospital in Kenya in 2 sites in Cambodia. And so we knew that there was proof of concept, this actually works. But the novelty in what we had done was that we created a 2-part training, where one was online, self-directed learning, and this self-directed learning component was put on a platform that is already recognized by the regulatory body in Nigeria, where people can get things. Now, this reduces the face-to-face component to a short, intensive program, which involves a lot of mannequins to really bring out those clinical competencies. Now, working with the college, we brought this in, worked with the college to review the material and adapt to the Nigerian setting. And then working with the college to select consultants who are also training residents in teaching in all the 6 zones of the country. So they were trained. So we trained 95 consultants, 82 of them from the college. The next thing, we established 2 training centers, 2 centers of excellence. This is kitted up with all the training mannequins, and also we trained 2 coordinators, one in Lagos and one in Abuja, so that it reduces the time that people have to travel to go and attend these trainings. Well, because of the close relationship with the college in planning all the activities, the plan we had was to have the training of the about 130 senior registrars from these 2 sites. But we wanted to do it in such a way that this is not so much dependent on the program. We build an existing system. Residents are used to going for revision courses. They cover their own costs. But we wanted to reduce the travel time for the residents. So the college recommended that we could increase the number of sites trained from 2 to 4. And that really made a huge impact, like we saw in some of the centers. In some of the centers where we trained, the number of residents, the number of males and females was the same. Because, females who are looking after younger children find it a bit difficult to travel, from home for longer periods of time. But they were able to attend compared to other places where this was not the case. So that was real positive, for the program. Also, we incur any cost for training venues, because these was all existing structures, existing facilities within the hospital, within the college training facilities. So at the end of the program, we've trained 225 doctors, 95 consultants, 130 senior registrars, and 34 all those trained are female. Now going forward, the college has accepted they're carrying out the review, update of their curriculum, and this is going into the curriculum, so that becomes mandatory, that pre-part 1 exams, you have to do this. So this is the pathway to sustainability and impact. Now what is exciting about what we have done is the catalytic effect we have seen in the training institutions around the country, where people who have been trained with little or no resources, improvising locally constructed mannequins, are conducting training for medical students, for residents. And this is happening even not just in the centers where we have put the equipment, but also in other places. And this is really heartwarming, because this is what we set out to achieve. So by the time over the next 6 months, 1 year, this becomes mandatory. We hope that with the extension we've just received, we build the capacity of the college to really examine, in all of these contents, using the right equipment for examination in an objective way. And I think this is the pathway to that sustainability we want to see, that quality of care, that will be provided in our institutions. Thank you.
Thank you very much. That was very interesting. Okay, I think we can move on to Dr. Oluwatosin Moteni. Yes, thank you. Can you tell us a bit about your partnership and what you've achieved, and what's the prospects for sustainability? What have you learned so far around sustaining it and scaling it up?
Thank you very much, and I'm really glad to be here. My name is Oluwatosin Moteni. I'm a neurodevelopmental pediatrician and the country lead for the Early Childhood Development Project, which is a partnership between Obafemi Awolowo University Teaching Hospital and the Royal College of Pediatrics and Child Health, also working in partnership with the other HRS Hospital, Liverpool, United Kingdom. And our partnership aimed at working together with the Osun State Ministry of Health to develop an early childhood development strategy for the Osun State, piloting with Osun State with the prospect for national scale-up. It's been a very interesting year going through the journey and learning, and I'm going to share with us what things we learned. We first identified gaps, and the huge gap include first the late presentation of children with developmental disabilities. I work in the hospital, and it was quite disturbing that many of the children who come for the first time with developmental disabilities will come at a very old age, as late as 10 years, when we have lost time for the brain. The first 3 years of life for every child is so important for any early intervention program to work. And unfortunately, in this part of the world, we also lack resource for most of the intervention programs, such that time is key when we want to really improve the outcomes of these children. We have found that children will be born in the hospital with developmental disabilities, but these are not usually identified early because the healthcare workers who might have attended to the children at birth do not have the skill to identify some of the disabilities. So there are a lot of missed opportunities. We identified immunization clinic as another very important opportunity for intervention, but these children would go for immunization, but developmental screening was not incorporated. We had the immunization card, but there was no systematic way of doing developmental screening at the primary healthcare facilities and across the tiers of healthcare. And we also identified a gap in referral, where referral system was not existing from primary to secondary and tertiary care. And at the tertiary hospital where I work, we did have a multidisciplinary team that's been in existence for about 7 years, and we had in this team, developmental pediatric team, the physiotherapists, occupational therapists, speech therapists, audiologists, pediatric ophthalmologists, and ENT, as well as audiologists. But we were having the problem. We were interested in helping the children, but to come together and have mental assessment was a problem because there was no space. people would have to wait outside at the waiting area and not be able to see the children. So we brought together all of this to develop this early childhood development project, addressing these various gaps at the primary healthcare level, secondary healthcare level, and tertiary healthcare level. Our strategy was to build capacity of the frontline health workers at the primary healthcare facilities to identify developmental disability and delay early as when the child is born, as when they attend immunization clinics. So we developed a program together with our partners from the GHWP hospital, using culturally adapted tools that we used in other African countries, precisely the Malawi Developmental Assessment Tool. And the tool is so designed that we had something that was simple enough to be used at primary healthcare level to just spot developmental delay. That's called that sign, and you can do that within 1 to 2 minutes. And then we had something that was a little bit more advanced for secondary level care, and we had a robust that assessment tool for tertiary level assessment, so detailed assessment. And we rolled out training for these frontline health workers at the primary healthcare facilities. We trained health workers in 19 primary healthcare facilities. So in total, we have trained 292 health workers in primary and secondary level facilities to use this to identify delay. And we provided the referral pathway using focal persons at these facilities. And with this, we were able to link them up with 3 secondary facilities where the second level of screening is done, and every child who is spotted and needs more advanced care can then be referred to the tertiary facility. At the tertiary facility, we also created a child development center. This was refurbished through this project, and one major main point is that this has been incorporated into routine service in the hospital, and the multidisciplinary assessment of these children go on in the child development center. Then to periodically of the health workers at the tertiary level, we had a bi-directional learning program through the exchange program. We had 7 of the multidisciplinary team members go to the GHWP hospital in Leopold for 2 weeks to learn, to observe, and to build a lot of capacity. And we had clinicians from Harder-Hay, 9 of them also come to Nigeria. They were with us for 2 weeks, and we had that very rich time to develop assessment programs and also see the children first, and they were able to provide a lot of support for our team. And in all, we have been able to have about 4,000 children assessed, and among these, we have identified those who have developmental delay. And we have also been able to add on to this project a training program through the Baby Ubuntu Hub. Baby Ubuntu program is a partnership between Ubuntu and the Lagos Club Tropical Medicine and Hygiene and Uganda, and we had 2 people come to us to train 5 expert facilitators. That's a pair of parents and 5 health workers. Together they have had training of 5 teams of caregivers comprising of 10 caregivers. So a total of 50 caregivers or 50 families have benefited from this training. It's been a great learning opportunity, and the opportunities for scale-up. One initiative I think we have enjoyed, because in starting this project we engaged with the State Ministry of Health, and we have continued to engage with them both at the Primary Health Care Development Agency and the Ministry of Health and the Hospital Management Board. At our last engagement meeting, the state was very happy with the output, and they are really eager to have a statewide scale-up, and they even did say that they would like this to be taken up by the National Council for Health. So that's mean that we can have a national scale-up. We have successfully incorporated developmental screening into routine immunization, having a 1 package. I brought a copy here. So we have this package that every mother goes on with that has both the child development pack and immunization pack, and we hope that this can be something that is available for everybody. In the UK book that every child goes on with, but here we don't have something that has that kind of detailed developmental screen. So that's an opportunity for scale up nationally, because immunization happens all across the country. And we also have facilitators that have been trained now. So Professor Glaston does not have to come from the UK to train us anymore. To spread this wide, we have people who have been trained as master trainers that can train on the various assessment tool for secondary and tertiary level. And we're hoping that this will go on to affect all. The burden is huge nationwide, and there are a lot of families that really want to benefit even from the parent training. We hope that that can be expanded to as many families as possible. Thank you.
Thank you. Thank you very much. That was very interesting. Okay, I'll go straight to Dr. Afolabi Fajemilo. Yeah. Can you talk a bit about your partnership, what you've achieved, and how it's been sustained, and also challenges, recommendations?
All right, thank you. My name is Afolabi. I represent a health partnership, SG38, consisting of First Foundation. First Foundation is a disability focus with significant attention on people with spinal bifida and hydrocephalus, while SHI UK is a national charity for people with spinal bifida and hydrocephalus in England, Wales, and Northern Ireland. So in our health partnership, before the commencement of the project, the gap we observed that our public health facilities, there were no dedicated continence management clinics. So, because it's been an ongoing project since 2017 before the GHWP grant, which we scale and those that are rubbing on the expected outcomes of the project. So, our partnership decided to support the establishment of dedicated continence management clinics in public health facilities, and then strengthen the skill, knowledge, and capacity of nurses to be able to deliver quality continence management and care within the scope of clean intermittent catheterization, boil washouts, measuring bladder, and then oxybutynin installation. So we first established a developed partnership with 8 public health facilities in 5 of the 6 geopolitical zones and in the country, teaching hospitals, and then thereafter we developed training programs using research from our international parent member, the International Federation for Spinal Bifida and Hydrocephalus, used in East African countries. And so we are able to train 89 public health facility outreach workers in the partner health facilities, and to be able to improve the life chances of children with spinal, being able to avoidable health complications, address their social issues, the daily challenges they face in managing bladder and bowel incontinence. Before the commencement of that project, parents have had a lot of conflict in addressing these issues. Some have to patronize herbalists. They spend a chunk of their income, buying diapers to manage this situation. There are, some health complications in the area of blood and kidney damage that could ultimately result into renal failure. So we have strengthened the capacity of the nurses across the partner health facilities, and we established peer support network among the nurses to be able to exchange knowledge and access ongoing specialist support between specialist continence nurses from Wales and Nigeria. So there is a quarterly meeting so between specialist continence nurses in Wales and Nigeria, so where there is exchange of knowledge, some of best practices in terms of provision of quality continence management and care. So we've also recorded in tremendous outcomes in terms of being able to improve the well-being of children with spinal bifida in the area of, because it goes a long way, it has a chance of effect in terms of affecting their education. For instance, the child who is, incontinent is not able to, doesn't want to go to school. And that will ultimately impact negatively on his education. You have the adults among them that are having social issues and being able to engage in intimate relationship. Because part of the project, what we really do have is for the patient to go to either urology department, nephrology unit to access care. But for especially the adults among them, they have much more concern than that. Like I just mentioned, the issue of being able to establish intimate relationship. They want to know whether they'll be able to function, and then what is the future holds for what does the future hold for them in terms of being able to go into marriage and other social engagements. So what we also observe that there are some factors within the community level are rubbing off on the expected outcomes of the project, and so we introduce community outreach workers to come in and then attach to the partner facilities where we are working. So the outreach workers are trained in continence management care. So they are able to provide non-hospital based support. So they go visit the families at home and understand their concern, because continence management one out of multidisciplinary care that children with spinal bifida. So we've had whereby there are wrong perception in cultural religious belief. Fathers who stand in the way of not allowing their wives to bring their child to continue or use catheters to, drag urine, from their. So we now introduce the outreach workers, so they are able to go, visit the families at home, and the fathers show them, the importance and the, danger of not doing it, and they're able to showcase, stories of these are recorded, considerable improvement. And so we've seen many families who came and then, right into the process. So in terms of sustainability, we have developed, we produced around October, June, in 4 Nigerian languages: Yoruba, Igbo, Hausa, and Pidgin. So which are now available on social media to sensitize the public and increase public awareness on the danger of not accessing bladder and bowel management for children with spinal bifida. With entry to showcase the impacts of the project, promote good incontinence practices among affected families, and that is going, it's really changing tension within the families, and the nurses in the partner health facility where we are working, they are able to also participate knowledge among their colleagues, and more nurses are coming on board to show interest in so the challenge within the health facility where we're working on is the mainstreaming of continence management and care within the regular hospital service. So, and that's why we'll be advocating to Federal Ministry of Health, to ensure that, continence management care and service become, part of hospital regular service, so that, if many of the health facilities where we're working still doing that side service, and so nurses who are providing this care are not well, encouraged, and so we're advocating for the service to become part of it, so whereby on monthly nurses roster, nurses will be posted, and because we have the clinic established within the public health facilities now. Thank you.
Thank you very much, and it's great to hear that, because we have the THET heavily represented here with a number of directors. So you've heard the recommendation from the partnership. Okay, I think next I would like Professor Akonde, very briefly, because I'm told that we are running short on time, to just talk about your partner, what you've achieved, but more importantly about sustainability and how you've been able to facilitate that. Thanks.
Thank you very much. Good afternoon, everybody. I am Professor Akonde, and I represent the National Postgraduate Medical College of Nigeria. Our partnership was with the Royal College of Pathologists, the Ghana College of Physicians and Surgeons, as well as the Aga Khan University in Kenya. The strategic objective was to build capacity, clinical service capacity amongst very young, newly qualified chemical pathologists, as well as to identify training facility deficits, and to try as much as possible to see how we can improve capacity in countries where the chemical pathology specialists are lacking. So the gap that was identified was that we noticed that the clinical service provision by newly qualified chemical pathologists, particularly in Nigeria, is not as good as expected. So we noticed that the clinical services are not supported by good result interpretation. And that gap was identified as a kind of training deficit in clinical application of the subject matter. Also noticed that there was a gap in Ghana. Ghana, as we speak, does not have a qualified chemical pathologist. And in Kenya, in addition to not having a qualified chemical pathologist, we identified too that there were deficits in training facilities. So these were the gaps that were identified. And what do they do? For the building capacity in the clinical service, we set up webinars, quarterly webinars, as well as monthly case presentation, where we may make very common cases in Nigeria, and with the help of our partners in Royal College, we're able to identify personnel that could take up on those cases, and we're able to collaborate in discussing those cases, how to go about improving the clinical application of the management of those cases. For the Ghana, we had to put up a strategy of an online monitoring program. So throughout the project, we are doing online monitoring with the 2 residents that either two had their program stored because there were no mentors and there were no teachers to carry them on. So we had to start an online monitoring program, and to the glory of God, as we speak now, they have moved from their stagnant position to the point of now presenting a dissertation to the Ghana College of Physician and Surgeon in order for them to be qualified chemical pathologists. And it is hoped that the sustainability plan along this line will be that these 2 will further now go into training some other chemical pathology in Ghana. For the Aga Khan University, we have to set up a machinery that could produce the basic tool in training, which is the curriculum. So we had to develop a curriculum for fellowship training in Aga Khan University in Kenya, and this was done in partnership with resource people from the Royal College, as well as myself, to harmonize the curriculum of the Royal College, the National Postgraduate Medical College, as well as the existing curriculum for a master's degree program in chemical pathology in Kenya. This was achieved, and we have produced the curriculum. The sustainability plan along that is that we are paid advocacy to the university, and the curriculum has been adopted by the university for further implementation. The challenge there is that as a university system, a new curriculum has to undergo certain procedural processes within the university. That's where we are now, and I'm sure this will be solved because of the advocacy that we have paid to the various organs of the university. The last thing was we conducted what they call a point of care testing program, training program in Kenya, and this is to address the fact that we have paucity of rural laboratories, and in order to substitute for that, we talk about how people can use health devices to improve laboratory services in the rural areas. So we did a 12 weeks online program, training program about that, and it came out successful. We had 8 out of the 10 participants that completed the program, and we had, in addition to that, a 3-day in-house training, hands-on training on this POCT equipment. The sustainability plan is that, the Kenya government, Ministry of Health, has bought into that, and they're going to scale up that training program in Kenya. Also, a capacity has been built as to how to obtain the ISO 15189 standardization of POCT equipment and usage, as well as governance in Kenya. I think these are the few things that we have been able to achieve within the 1 year, and I'm very, very happy to report that we have been very successful. Thank you very much.
Thank you very much. Yeah, these are very interesting partnerships. Do we have any questions from the house? Okay, we have one there. Any other question? Okay. Okay, so there's a gentleman at the back.
1, 2.
All right, good afternoon. Thank you very much for this very insightful discussion. I'm very sure if what is being discussed about here is being implemented, it's going to improve the global health force. Okay, my question, you know, the objective of projects is actually in its sustainability. I want to ask, what strategy have proven very effective in ensuring long-term sustainability of projects, especially in resource-limited settings? That's one.
Sorry, who is that directed to?
Okay. I think it's directed to, I don't know his name now. I was just jotting behind. Yes, sir.
Which one?
Yeah, he just lifted his hand.
Just, okay, describe the person.
Yes, he just lifted his hands now, sir.
Okay, all right.
All right, so I have two questions actually. So the second one now is, what role does local community engagement play in ensuring ensuring sustainability of interventions? Thank you very much.
Can you just introduce yourself?
Okay, my name is Mr. Stephen Joseph Abo. I represent Parasitology and Public Health Society of Nigeria, Niger State Chapter.
Thank you. Okay, any other question? If not, okay, over to you, sir.
Thank you very much for those interesting questions. So I think one of the things for success for any project is just making sure that you do your stakeholder mapping from the beginning, because you need to engage the right people if it's going to be owned and if it's going to be sustained. What we did was that the project was designed from the start with the institution that could lead to a sustainability of that intervention. That's the National Postgraduate Medical College of Nigeria. So they were involved in designing, in implementing, in reviewing, and have complete ownership. So some of those bottlenecks that we had anticipated as risk during implementation, because of that relationship, they were able to unblock a lot of those things. And I think that is what I would recommend, going forward. Regarding your other question, which is, like community engagement and involvement. So for us, for our program, our community, as it were, will be the teaching hospitals and the residents. And we're able to engage them through the college and through the management of those training institutions. Even where we had pop-up training centers, through the intervention of the college, through the CMDs, we got to use facilities without paying anything, even where they had a policy for payment, because this was seen as something beneficial to that community. Thank you.
Thank you very much. Thank you for that. Very interesting partnerships. It's been great hearing of your inspiring work, and we as you continue to work. Thank you. A round of applause for our
very much. And also so can we, just like as we did to other groups, can we just stand here for a group photograph? Where's the photograph? Are you here? So, thank you, Pro. Let's just stand in front here for a group photograph. Then thereafter, I will want thank you, sir. Thank you. Yeah. So thereafter, as the photograph is going on, I want to call on Dr. M.B. Olatunji, the Executive Secretary of your State Primary Healthcare Board, to prepare to give comment on this last discussion, particularly on the LG06 and SG41, which deals with occupational health and remote consultation in PHCs. We just want you to react to how far these two peers has impacted your state and the plans that are left on the ground by you to sustain. Please, can somebody give him a microphone? Please, Dr. Olatunji, MB.
In Yoruba land, there's a wise saying that says, a culture or an idol or a god, you don't want to go into extinction in worshipping after your demise. Make sure that you have your child planning from the start, so that after you pass on, they can sustain the legacy. From the one of the two projects, the State Primary Care Board was fully involved in the designing, in the protocol and the rules of engagement, so we are part and parcel of it. So it's not like they're doing it for us, it's that we are doing it together. Okay. And that we got a clear view of what you actually wanted to do. As for the remote consulting, you will agree with me that generally in the country, we will be described as a resource-limited country, especially as far as human resource for health is concerned. And the remote consulting now helps us close that gap a little bit, because the health workers are seriously overwhelmed. They couldn't add the discharge as expected because they are limited in number. So the remote consulting gives the opportunity for us to be able to deliver to the people in the grassroots. The community members can actually have the benefit of qualitative healthcare service delivery, because it enhances their performance to be able to discharge services. And this is the kind of innovation that allows us to leverage on the information technology and actually helping us to push our cause. It's what we actually wanted to do, but somebody is now coming to lead us on how to do it better, and it becomes so easy for us. And as a state, we are already on the pathway to sustain that. We are leveraging on the Basic Healthcare Provision Fund and impact projects that we have in our states. For instance, we are the basic healthcare facilities, whereby we make funds available for them. For instance, the procurement of to be able to make on the client, and then to do a kind of a follow-up. One, it reduces the time spent for the patients when they don't actually need to come to the facility. If the consumer only require encouragement and word of view, they don't actually need to come to the facility. So it reduces the time wastage in shuttling between facilities. So become convenient. So we want to be able to continue and sustain this the way it is, and we might even expand beyond the existing facilities as it is now. So minimum between 351 facilities might be the one to be rolling down out in short course that we are doing. And the engagement, we have the research team in UCH under Professor Omigbodo, is something we want to cement. Even if your funder stops, the state is not likely to engage in them, because with something we want to benefit. It's the same about relationship, and because we believe we are benefiting from it, so we want to keep up on that trajectory. You can ensure that something sustainable. Then on the occupational health.
The occupational health.
Yes, in the same pathway in the starting. And in a few weeks ago, we have actually had an engagement in which the state made a commitment to sustain this. And one of the way of doing this is to ensure that at the primary care board level, we are going to have a desk officer on that particular project, not only that one again, across all the local government areas. We'll have a program officer that will be able to run it, so that there will be better coordination. Again, the source knowledge, which is the UCH under Professor Omiko, will not go into extinction, so we want to be able to work together and make sure that we want continuously. Thank you, and God bless you.
Very much. Thank you very much, Sir Dr. Olatunji. Thank you. We are sure that by the time the project ends, it's not good. The part of it is not going to end like that. That the different states, they will continue to build on it, so that our
people will definitely benefit from the investment that have been made on that. Thank you very much, Dr. Latunji. On that note, I think we want to go for our lunch now. We have actually eaten 15 minutes. We are going to do that in order to compensate for the time lost, but we'll try our best to see that we don't overstay in this. So what we are going to do is that we move in 2 batches, because I was told, or I have been told, that the places for the lunch, they are in 2 places. One is in the restaurant, another one again is behind the restaurant. There's a garden there. So the plan they have, the management have for us is, the first 3 rows, we go through this gate. Somebody will lead them to the restaurant, while the other last 4 rows, or the ones behind, they will go through this gate. Somebody else again will lead them to the venue. So I think on that note, we need to go for our break so that we'll be able to meet up with our time. Thank you very much. Please don't forget to go with your meal ticket.